Good evening, everyone. I'm Andrea Foti, and I'm the Deputy Registrar and Privacy Officer here at the RCDSO. Welcome to this evening's RCDSO Connect session. This is our fourth virtual session in 2026, and we're so pleased that you're with us tonight. Tonight's session is on professionalism in practice. As you know, professionalism is a cornerstone of dental practice. It shapes how dentists interact with patients, make decisions, and contribute to the health of their communities. Tonight, we're going to explore the college's new document, Foundations of Professionalism. We'll highlight four key bioethical principles that the document's based on: patient autonomy, beneficence, or doing good, nonmaleficence, or doing no harm, and justice. We'll also examine how these principles apply to everyday clinical and professional situations. For our time together tonight, we are going to have a presentation on the Foundations of Professionalism document that will really take you through the document's contents and give you some insights into how it was developed and finalized. We also have a moderated panel discussion for you. We've got a great panel comprised of dentists in practice, and we are going to walk through different scenarios related to professionalism and offer practical guidance and reflections on how some of those scenarios could be approached. We do have a Q&A function, and you'll see a button in Zoom for that. Please feel free to submit your questions to us. We're going to do our best to get to as many as possible. It's likely not possible that we'll get to everything, but any questions we don't answer, we will be reviewing. Tonight's session is eligible for 2 points in Category 1 toward your CE requirements. And to gain those 2 points, you've got to attend tonight's session for at least 75 minutes. I'm going to turn next to a practice that's really become a staple for RCDSO meetings, and that's our land acknowledgement. I'm going to be reflecting on the lands on which the RCDSO offices are based. So the RCDSO is based on the traditional lands of a number of Indigenous peoples: the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Huron-Wendat peoples. And these lands are known today to some as Toronto. Toronto is covered by Treaty 13 with the Mississaugas of the Credit, and it's home to many diverse First Nations, Inuit, and Métis people, as is Ontario as a whole. This land is also part of the Dish with One Spoon territory, a treaty between allied nations to peaceably share and care for the land. From the RCDSO's perspective, we accept our responsibility to each other and the land that we live and work on in a spirit of peace, friendship, and respect. We're committed to actively supporting the necessary work towards truth, reconciliation, and equity. And we embrace our role in regulating dentists, in protecting the public interest, and strengthening our partnerships with Indigenous communities to advance access to safe and equitable oral health care. I'm pleased to turn now to introduce our first speaker this evening. With us tonight is Dr. Erin Walker, and Dr. Walker is going to be taking you through the new Foundations of Professionalism document, and she'll also be moderating tonight's panel. So let me tell you a little bit about Dr. Walker. She is a practicing dentist and owner of a family dental clinic, which has served her small town community for over 13 years. In addition to her clinical practice, she plays an active role in leadership here at the RCDSO. She serves on council. She's the chair of our Inquiries, Complaints, and Reports Committee, and she also sits on our executive committee. Dr. Walker was also a member of the working group that developed the Foundations of Professionalism document. So she really has had a front row seat in the active and ongoing debates that went into and contributed to the final document. She holds a DDS from Western University, an MBA, and an LLM, and she's currently pursuing a PhD in health law. All of this while continuing to care for her patients. So you can really see, and it's apparent for anyone who interacts with Dr. Walker, she has a deep commitment to clinical excellence, professional regulation, and lifelong learning. Dr. Walker was also the recipient of the 2025 Schulich Dentistry Young Alumni of Distinction Award. Her combined experience in practice, policy, and governance really position her uniquely to guide us through tonight's discussion. So, warm welcome to you, Erin, and we look forward to your presentation.
Thank you, Andrea. Good evening, everybody. I'm pleased to present the RCDSO's new Foundations of Professionalism document. I'm Dr. Erin Walker, a general dentist, and a member of the RCDSO's Council on Professionalism Working Group. The presenters tonight have no proprietary, financial, or other personal interests or relationships relevant to this presentation that could give rise to a conflict of interest. And all images included in this presentation were obtained via the public domain, unless otherwise referenced. So before we get into the new document, I'd like to provide you with some context. I will then explain to you how we developed the document, and will provide an overview of what's in the new document. I will then moderate a panel discussion where we'll work through scenarios and we'll highlight how the core principles and duties in the document can actually help dentists navigate challenging situations. Improving access to oral health care has been a priority of the college for years. Early work on this issue included holding an Access to Care Symposium in 2019 with multiple system partners. Access to care was then identified as a strategic project in our last two strategic plans. Our current Access to Care strategic project sits under the professionalism pillar in our strategic plan. And the college's objective is to create and promote a culture of professionalism in dentistry that supports access to quality care, serves the public interest, and upholds public trust. The Access to Care project under this strategic plan has 4 areas of focus: data, information sharing and education, professional expectations, and collaboration and engagement. For the last phase of the project, we've been focusing on the last 2, professional expectations and collaboration and engagement. In the interest of time tonight, my remarks will focus on these 2 areas, but you can find more information about this project on our Access to Care website. Our RCDSO Council directed that we develop professional expectations regarding professionalism and also accepting new patients into dental practices. So we decided to develop the Foundations of Professionalism document first, since it's foundational, and it will help inform the positions in the upcoming standard on accepting new patients. Professionalism can help access or increase access to oral health care by fostering a culturally safe, inclusive, equitable, and accessible environment that is free from discrimination. Improving access to oral health care has a direct connection to the RCDSO's mandate and supports patients' overall health and well-being. I'll highlight the collaboration and engagement strategies we use to create the new document when we talk about the process. This slide outlines our key objectives in developing the new document on professionalism. As mentioned, we wanted to update and modernize the RCDSO's Code of Ethics. Foundations of Professionalism replaces the Code of Ethics and more accurately and comprehensively reflects the current environment. The intention was not to create new commitments and duties, but to simply reflect the existing commitments and duties that dentists have and uphold in practice every single day. The document is intended to help navigate clinical and professional practice and ethical complexities that are certain to arise. The document serves as a foundation for all of the college's standards of practice, guidelines, and advisories. The document is high level, but comprehensive in the sense that it covers all of the core principles and duties that dentists have. Standards of practice and other college resources will continue to set out more specific requirements on issues or areas of practice, such as consent, boundaries, or record keeping. A working group was struck to assist with the development of the new college documents. The working group is composed of dentist and public council members, faculty representatives, and subject matter experts. The working group used the standards review and development process to develop the draft Foundations of Professionalism document. This is the process that we use to review and develop all of our college documents, including the standards of practice. You can see that we started off by conducting some desktop research, and we held a public consultation on the topic of professionalism in early 2024. The working group has been meeting since April 2024. We reviewed the desktop research and consultation feedback and used that information to develop a draft document. Council reviewed and approved the draft Foundations of Professionalism for public consultation in March of 2025. The working group reviewed the feedback we received from that, which was overall supportive of the draft, and we made some minor revisions to the document in response. Council reviewed and reviewed the revised draft document in September and approved it as a document of the college. I want to provide you with a little more detail regarding the research and the feedback that contributed to the development of the Foundations of Professionalism document. The research included a literature and jurisdictional review on professionalism. We considered over 40 professional documents other regulators and associations have published on this topic. We also considered information and data regarding the inquiries, complaints, and discipline matters that have come before the college. The right-hand side of the slide sets out the various consultation and outreach tactics that we use to obtain feedback. In addition to the 2 public consultations I already mentioned, we consulted with the Citizen Advisory Group, which is a group of patients and caregivers that provide feedback to Ontario regulators. And we spoke to attendees at the ODA annual spring meeting and at various conferences. We also held RCDSO Connect sessions on this topic and used an external research firm to poll the public. Our outreach was extensive, and we wanted to make sure that we really heard everyone's perspective. Now let's turn to the document itself. This is how the document is structured. It starts off by providing an overview of the document and describes the core components of professionalism that underpin the document. It then sets out the core principles and duties of the profession. The overview clarifies that dentists are expected to practice in accordance with the core principles and duties in this document. It also shows how these principles and duties are organized under the bioethical principles of patient autonomy, beneficence, nonmaleficence, and justice. The document describes the core components of professionalism as prioritizing the well-being of patients in society and upholding fiduciary duties. Fiduciary duties are set out in law. Fiduciary law governs the legal and ethical relationships between dentists, who are the fiduciaries, and their patients, who are the beneficiaries. Some key fiduciary duties include, but are not limited to, acting in patients' best interests, acting with integrity, honesty, trustworthiness, and the utmost good faith, avoiding conflicts of interest, protecting patient confidentiality, and providing access to patient records. The principles and duties set out in this document build on core components of professionalism that we just covered. They reflect dentists' broad responsibilities to patients, society, the profession, and themselves. They represent what patients, society, and dentists consider important. They serve as a framework for dentists' individual and collective conduct. They help dentists navigate clinical and professional practice and the ethical complexities that are certain to arise, and they support dentists in maintaining the highest possible level of confidence and trust with respect to patients and society. The first bioethical principle is patient autonomy. It is described as follows. Patients have a right to self-determination, including the right to make their own decisions about their healthcare and to privacy and confidentiality of their personal health information. These rights need to be acknowledged and respected by healthcare professionals. The document describes the different ways in which dentists respect patient autonomy, including obtaining informed consent for treatment in accordance with legal and professional obligations, and providing patient-centered care that upholds the standards of practice of the profession. I'm only highlighting 2 examples for each principle during this presentation, but I would encourage you to read the document so you can familiarize yourself with all of the core principles and duties. The bioethical principle of beneficence is actively serving and benefiting patients and society. Dentists also do good by maintaining and enhancing the health and well-being of patients and society and recognizing the interconnectedness between both. This document describes the different ways in which dentists can demonstrate beneficence, including acting first and foremost for the benefit of patients and in service to their health and well-being, and collaborating and communicating effectively within professional relationships and facilitating continuity of care. The bioethical principle of nonmaleficence is avoiding doing harm to patients and society and protecting them from harm. The document describes the different ways in which dentists demonstrate nonmaleficence, including complying with legal, professional, and ethical obligations set out in law and by the RCDSO, maintaining competence, recognizing limitations, and referring to other health professionals when necessary. The bioethical principle of justice is treating all people fairly and equitably. The document describes different ways in which dentists demonstrate justice, including complying with legal obligations with respect to human rights and accessibility, and promoting health and preventing oral diseases by understanding and taking reasonable steps to understand and address the determinants of health. For example, by participating in incentives to reduce the health inequities that are driven by these determinants of health. Now, participating in publicly funded oral health programs, like the CDCP, could be one initiative that dentists participate in. However, I want to clarify that this document does not require dentists to participate in any specific initiatives or programs. We have also developed companion resources to help dentists apply the document to practice and to help patients understand what they can expect from their dentist. This includes frequently asked questions, a dentist checklist, a patient resource, and case scenarios. These resources are available on our website with the exception of the case scenarios, which will be released soon. We'll notify you once they're available, so definitely keep a lookout. One last point I want to emphasize, Foundations of Professionalism is designed to support dentists as we navigate challenging situations in practice. It's forward-looking, meaning you can take the principles and duties outlined in the document and apply them to whatever situation you're facing. This document won't give you a step-by-step answer or tell you exactly what to do. Instead, it gives you a framework to help you think through the options and exercise your professional judgment. That's very different from a standard of practice, such as the one on record keeping, which sets out specific requirements on what you need to document. Foundations of Professionalism doesn't do that. It provides the structure and your professional judgment fills in the rest. So next time you encounter a challenging situation, we invite you to refer to the document. I wanted to share some concrete examples of what professionalism can look like in everyday practice. These are actual examples that we heard directly from you through our consultation and engagement activities, including at the in-person RCDSO Connect session in London in 2024. Treating patients, colleagues, and staff with respect. Complying with legal and regulatory requirements such as IPAC. Referring patients to other healthcare professionals when necessary. Seeking out continuing education and providing safe and accessible care for equity-deserving populations. taking steps to make practices more accessible for people with disabilities, voluntarily participating in publicly funded dental programs, such as the CDCP, offering reduced fees or payment plans for patients who need them, providing emergency dental care regardless of ability to pay, and volunteering in the community or abroad. I'm not saying that all dentists are required to do all of these things. These are simply practical examples shared by you and your peers of how professionalism can and does show up in everyday practice. I also wanted to share this photo from Western's Professionalism Day, which took place last September with first and fourth year dental students. Students were asked to write down one thing they profess to doing to advance professionalism in their careers. I know you won't be able to read this, so I'll share some examples with you. Be truthful. Listen first, think second, act third. Self-reflect. Always act in the best interests of the patient. Treat patients solely based on their needs. Do not overtreat. Be kind and fair to everyone. Treat patients with respect. Take time to get to know patients and understand the determinants of health. Keep learning and stay humble. Seek out help when needed, and seek out mentors. These examples touch on all of the bioethical principles and demonstrate a really strong understanding of and commitment to professionalism. Now it's time to hear from our panel. I'll be monitoring the panel discussion, and I'm pleased to introduce you to the following panelists. Dr. Nancy DeSanto is chair of the Quality Assurance Committee at the RCDSO, where she plays a pivotal role in upholding professional standards and promoting continuous improvement in dental care across Ontario. A graduate of the University of Toronto's Faculty of Dentistry, Dr. DeSanto brings nearly 3 decades of clinical experience and leadership to her role. She has served on our RCDSO committee since 2014. Passionate about lifelong learning, she engages in continuing education and regulatory innovation, including the development of the college's e-portfolio system. Outside of her regulatory work, Dr. DeSanto practices family dentistry in Vaughan and is deeply involved in community philanthropy. Her commitment to excellence in public service continues to shape the future of dental regulation in Ontario. Dr. Kevin Hockley is the Associate Director of Clinics and an Assistant Professor of Clinical Dentistry at the Schulich School of Medicine and Dentistry at Western University. A graduate of Western's Faculty of Dentistry, Dr. Hockley brings over 3 decades of clinical, academic, and leadership experience in his role. Dr. Hockley is actively involved in organized dentistry, serving in various roles within the National Dental Examining Board of Canada, Association of Canadian Faculties of Dentistry, Commission on Dental Accreditation of Canada, and the Royal College of Dental Surgeons of Ontario. He is a fellow of the American College of Dentists and recipient of the Ontario Dental Association's Award of Merit. Dr. Bonnie Yu is a dental public health specialist and a fellow of the Royal College of Dentists of Canada. She's a dental analyst and consultant in the Professional Conduct and Regulatory Affairs Department at the RCDSO and the clinical lead for the college's Access to Care strategic project. Before we get into the panel discussion, Drs. DeSanto and you are going to share 2 key resources with you. I'll first hand it over to Nancy to walk you through the dental checklist, followed by Bonnie, who will introduce the patient resource.
Good evening, and thank you, Erin. I'd like to now turn your attention to the checklist for dentists which accompanies the professionalism document. Why does this checklist matter in daily dental practice? This checklist is a reflection and a decision support tool. I like to refer to it as a thinking tool or a professional compass. It helps you pause, reflect, and choose your professional action. Use it in the moment when you're unsure, and when you're documenting clinical notes and record keeping. Now, I will briefly describe the how to use it. I like to think of it as a three-step mental workflow, not a long list to memorize. So step one, identify the issue. Ask yourself, is it mainly about patient choice, benefit, risk, or fairness? Then scan the relevant section and map the issue quickly using the checklist. Focus on the principle involved. For example, if it's a consent issue, scan patient autonomy. If it's a safety or competence issue, scan nonmaleficence. Step 3. Ask yourself these two key questions. Can I clearly justify my decision based on this principle? And would I feel comfortable explaining this decision to the patient, a colleague, or to the college? Now I will turn things over to Bonnie as she highlights the patient resource component. Bonnie?
Thank you, Nancy. So as you can see on the screen, we have the patient version of the checklist. The 4 bioethical principles are explained in patient-friendly language. For example, patient autonomy is explained as the dentist is required to respect your choices. Beneficence is explained as act in your best interests. Non-maleficence is explained as protect you from harm. And justice is explained as treat you fairly. The dentist's duties are also explained in a condensed way in layperson's language. For example, the dentist's duty to promote health and prevent oral disease by understanding and taking reasonable steps to address the determinants of health is simplified to address the factors that impact your health and well-being. The checklist reiterates the message that dentists have a professional duty to act in the best interests of their patients and uphold high standards of care. Finally, the checklist is meant to empower patients, tells patients that they have a role to play, they're encouraged to ask questions, seek clarification, and be active participants in their care. The checklist ends with a resource link to the full Foundations of Professionalism document and the college contact information. Thank you.
Thank you, Nancy. Now we're going to run through some scenarios with our panel members. I'll lay out the scenario, and then we're going to turn to each panel member to go through some of the principles and what they would do in practice. So our first scenario is for Kevin. A patient arrives at a dental clinic requesting the extraction of a molar that causes mild discomfort, but is otherwise healthy and restorable. They explain that they've had previous issues with the tooth and they want it removed to avoid future problems. Upon examination and review of the radiographs, dentist finds that the tooth is structurally sound, it's restorable, and it's surrounded by healthy adjacent teeth. Now, while the dentist understands the patient's concerns and wants to respect their wishes, they also recognize that extracting a viable tooth without clinical justification falls outside the standards of practice of the profession, and it poses unnecessary risks, such as long-term functional and occlusal complications. So the relevant bioethical principles to consider in this scenario are patient autonomy, beneficence, and non-maleficence. So Kevin, can you speak to the relevant principles and explain how you would weigh them when deciding what to do?
Sure, I'll do my best, Erin. Good evening, everyone. The first principle as it relates to this scenario, as you've learned about already this evening, is that of patient autonomy. And while this may appear to be obvious on the surface, it can create some conflicted emotions and thought processes, as we all know. The patient wishes to have the tooth out. Therefore, on the surface, if we're allowing them to flex their autonomy, if you will, should we just take the tooth out? Well, this conflicts with the standard of practice as mentioned in the scenario, removing an otherwise healthy tooth. So part of the patient, ensuring that the patient has autonomy over their treatment decision is ensuring that they have all the information that a reasonable person would need to make an informed decision. And this to me is the crux of this whole principle and things that we do every day with honoring autonomy, but also making sure that we provided proper informed consent. So this weaves in nicely to me with the consent to treatment document. While autonomy is certainly about respecting patient choices, we need to be sure that the patient is informed enough that they don't make the wrong choice. Which takes me to the principle of nonmaleficence. We need to ensure that we don't end up rendering a treatment that may appear to solve a short-term concern, but inadvertently or accidentally introduce more liabilities for the patient in the future. This is especially important when we're rendering irreversible or invasive treatments such as an extraction. We wouldn't want to inflict harm or create a scenario that will limit a patient's future treatment options. Well, today they sit in our chair and say they want the tooth out. Is that a decision that a reasonable patient would really make? Would their future self make the same decision is a question I might ask. And also importantly, are there factors in their life that are present today that might be influencing this decision and causing them to make possibly an irrational decision? And finally, weighing in on the principle of beneficence. What is truly in the best interest of this patient? We are the subject matters experts in dentistry, and I, as the dentist, need to ensure that the patient doesn't make a decision that they could potentially regret for the rest of their lives. I would ask myself if I've provided them with all of the information a reasonable person would need to make a decision about the current situation, and that would include future treatment options. This may seem like a silly anecdote, but for the folks in the audience that are Western grads and we're fortunate enough to be under the tutelage of Dr. Wes Dunn, I think of this little story often as he communicated it to in our professionalism and ethics course. When making a difficult decision and being pressured by a patient to perform treatment that you're really not quite sure about whether it should be completed or not, simply ask yourself, if this was your sister, your mother, your brother, would you allow them to make this decision? And that's something that I ask myself every day.
Thank you. Can you share with us how the new Foundations of Professionalism document can help dentists navigate this scenario?
Yes, I can try. I really like this tool. I find that it is effective. I think the way that it breaks it down, and the checklist is certainly even more helpful, but the way it breaks these principles down into the individual categories and has the checklist with individual questions, I think it's a great tool to help dentists in making these decisions. So with respect to patient autonomy, in this particular scenario, I would want to ask myself if I provided clear and accurate information and make sure that the patient understands. So it has to be in language that they understand. I also think very, very importantly, that the active collaboration and shared decision making, that sounds like a buzz statement, but it's very true. It's something we need to definitely do, is involve our patients in shared decision making. And the crux, as I said before, to me is obtaining consent for treatment. I would ask myself, did I make sure that I listened very carefully to the patient and answered all of their questions? If we provide patient-centered care, that's going to uphold the standard of practice. Certainly taking this patient's tooth out in this situation, even though that's what they want, might not be the best thing to do. For beneficence, acting first and foremost for the benefit of patients and in the service of their well-being while collaborating and communicating with them. And to me, one of the other very important pieces here is including and supporting patients throughout their entire treating relationship. So in this case, the scenario makes it sound like it's a snapshot in time and it's a one-off and then it's done. But I feel like we need to remember that there should be an entire, a treating continuum or treating relationship here. So they don't have to make a decision today. We're going to be by their side if they need us in the future as well. And non-maleficence, we need to be accountable and take responsibility for our actions, our inactions, our decisions, judgment, and competence. So in this case, we're going to make a decision potentially, if we honor the patient's wish, about taking a tooth out. We have to live with that action. We have to live with that decision and that judgment. And above all, always making sure that the patient's best interest remains paramount when we make these clinical decisions.
Now, Kevin, say you've explained everything to the patient, you've answered their questions, you've given them time to think about how they want to proceed, and they still want the tooth out. What would you do in this case?
Well, because that never happens in real practice, right? It happens all the time. It's something we face every day. So in this case, I think sometimes patients may feel that claiming that the extraction is the only treatment they can afford. We have to be careful in this situation. The question I'd ask myself is this still in the best interest of the patient? Most dentists will recognize the fact. I think we've all had patients feel that they want to request the removal of a tooth or teeth because they feel like this will be the end of their problems. Once the tooth's gone, doc, I don't have to think about it anymore. Whereas we know that it's the subject matter experts that this is often the beginning of their problems. So again, have we taken the time to explain this to the patient? Have we discussed the long-term restorative or replacement liabilities and what the costs are of that, what the ongoing maintenance costs are? If they're going to have an implant, they have to have regular maintenance, the possible complications. Have we explained all that to them? Would they then still make the decision to remove the tooth? I also think it's important to remember that, and in this case, it's a scenario, it's not real world, but often, is extraction the only other option, or is there something we can do to make the patient comfortable and save the tooth? So sometimes there could be an interim measure to maybe buy some goodwill with the patient and allow them to be in a better frame of mind down the road, and sort of build a little bit of trust with the patient as well.
So if the patient becomes upset after you decline to do the extraction, what strategies would you use to manage this situation professionally and to maintain the trust?
So, in my opinion, trust is key. Trust is paramount in the dentist-patient relationship. And one of the underpinnings, I think, for trust to me is to make sure that the patient is aware um, that you can put yourself in their position. So, are you acting in their best interest? If they feel that you're acting in their best interest, that will often build trust. I would empathize with the patient. I wouldn't dismiss their concern or their desire to have the tooth out. Again, as I said earlier, patients often think that that will fix everything. So I would want to try to put myself in this position and understand and let them know that I understand they just want the problem to go away. But my job would be to explain that that's a one-way street and an irreversible treatment. If I haven't already explained the consequences of removing the tooth, I would definitely have a deep dive into that conversation in what this might look like long term for them. And I would try to reinforce that the apparent short term solution will, in the end, cost them more, not just financially, but potentially from a quality of life perspective. So I think I say it often to students, if the patient knew what we knew, they'd probably make the same decision we would make. So to me, this scenario is really a good scenario, not just for the foundations of professionalism, but also for consent to treatment, because it weaves together nicely, I feel. Um, the other thing with this particular situation, and I said it earlier, is about maintaining trust. I want to reassure the patient that I'm not going anywhere and I'm going to be here. And this is a snapshot in time today. I know they're feeling this way today. And I would, again, empathize that. I wouldn't empathize with them on that. I wouldn't dismiss it. But I would explain to them that I'm here to support them in their care moving forward as well. So if situation changes or worsens, I will be here for them. I will be here to support them in any additional future treatment decisions that we can make together in their best interest. Because I feel like sometimes, this case, the patient says it's uncomfortable, it's not painful, but people who are in pain they're not good decision makers. So, uh, and I feel that in my experience, patients are often more afraid of what might happen than what is actually happening. So I think most folks would agree with that. So again, just maybe giving them that additional support to say, hey, we don't have to decide this today. I'm here for you if you need me. If things change or if the pain worsens or the discomfort worsens, we can deal with it then.
Now, along those lines, if you decline to do the extraction and there are no other providers available in your community to see the patient, what are your responsibilities?
That's an interesting question. I guess I would feel that my responsibilities don't really change if I'm following the document and my judgment, my clinical judgment, then I would be trying to steward the patient along to help them make a decision that's the best decision for them. Uh, it might be different if it was an acute situation involving maybe severe pain or infection or something like that. If I was in a remote area, um, but I think the responsibilities remain the same as far as the foundations of autonomy, non-maleficence, and beneficence for this scenario. Now, if the question is looking at a scenario where the patient can't get another second opinion, because there's no other providers in the area, well, I still feel like I have to stick by my clinical judgment in this case, and hopefully it's guided by what's in the patient's best interest, because the long-term consequences to the patient in a situation like this where it's an otherwise healthy tooth, the long-term consequences don't change for the patient. By removing a healthy tooth, the problems, the complications, the long-term liabilities remain the same. And while admittedly it might have fewer options, I'm not sure that it would change my responsibilities. And I know we talked about this before, Aaron, as well, but I just wanted to reiterate from my perspective as well that it's important that the dentists understand that, when we do this scenario, when I've done this scenario, and the purpose of the foundation's document is to ensure that, like, I would like people to know that this is my opinion and that this is how I've processed the information, the scenario, and I've reviewed it on my own. But it's not a black and white. It's not my way is the only way and there is no other way to do it. It's more about how I would use the document and how other dentists would use the document moving forward.
I think that's a really great point, Kevin. I'm looking at our little stats of participants here, and there's almost 2,200 of us here together tonight. So I can pretty much guarantee it that there's some people are sitting there thinking that's not what I would do in my practice.
There's more than one way to do it. That's right.
That's completely okay. And what this document is here for is to help you justify whatever you would choose under these bioethical principles. So thank you, Kevin.
Thank you.
Discussion. Let's move on to our second scenario. And this is for Nancy. And this scenario is about treating a patient who's living with a disability. So the scenario is as follows. A patient who uses a wheelchair and has limited mobility in their upper limbs arrives at a dental clinic for routine care. These physical challenges make it more difficult for the patient to maintain oral hygiene at home and to be comfortably positioned in the dental chair. The dentist, while experienced in general practice, has limited experience treating patients with physical disabilities. They feel unsure about how to adapt the clinical setup and treatment approach to meet the patient's needs. During the appointment, the dentist struggles to find a safe and comfortable position for the patient and feels uncertain about how to communicate effectively and respectfully without making assumptions or appearing insensitive. The relevant bioethical principles to consider here are patient autonomy, beneficence, non-maleficence, and justice. So here we have all four to work with. So some questions for Nancy. First of all, can you speak to us about the relevant principles and explain how you would weigh them in deciding what to do?
Of course. Thank you, Erin. Oh, thank you, Erin. I think I froze for a bit there. So one of the most important aspects of this document is that the patient's well-being is priority. This scenario brings to light several important bioethical principles in the context of providing dental care to a patient with a physical disability. Navigating this scenario ethically requires humility, a willingness to learn, and a patient-centered mindset. The dentist's good intentions must be coupled with actions that respect autonomy, do good, avoid harm, and ensure fair treatment, the cornerstones of ethical clinical care. I'd like to briefly discuss how each principle applies along with practical considerations for ethically and effectively addressing the situation. So let's look at the first principle, patient autonomy. defined as respecting the patient's right to make informed decisions about their own care. How would I apply patient autonomy in this case? So a couple of points that I considered. The dentist should communicate openly and respectfully, allowing the patient to express their preferences, needs, and any adaptations that have worked well in the past. The dentist should avoid making assumptions about what the patient can or cannot do. Instead, they should ask clear, respectful questions like, what positions work best for you during dental care? Or are there any accommodations that help make dental visits easier for you? So a key ethical focus here would be to ensure the patient is fully involved in decisions and their lived experiences are valued as part of their care process. So the second principle is beneficence, defined as acting in the best interest of the patient and promoting their well-being. How would I apply beneficence in this case? So the dentist must adapt care to suit the patient's needs. This could mean modifying the chair position, allowing more time for the appointment, or using assistive devices. The dentist can also provide advice for adaptive oral hygiene tools that could improve the patient's home care routine, and this also reflects beneficence. So an important ethical focus here would be going beyond just providing care. Ensure that the care actively improves the patient's quality of life and accommodates their specific challenges. The third principle is nonmaleficence. Again, defined as doing no harm, avoiding actions that could cause injury or discomfort. How would I apply nonmaleficence in this case? If the dentist attempts to move or position the patient without proper training or assistance, they may cause physical harm or distress for that patient. Non-maleficence requires the dentist to seek guidance or training when they're unsure and to avoid risky maneuvers without appropriate support from a trained assistant or a physical therapist. Another suggested opportunity, the dental practitioner may consider seeking appropriate training in rendering treatment to persons with physical and/or intellectual disabilities as one of their planned continuing education goals. The ethical focus here is to recognize the limits of one's expertise. Think to yourself, do I have the knowledge, the skill, the judgment to provide safe dental care and take steps to provide and prevent physical and emotional harm to the patient? The final principle to consider here is justice, defined as treating patients fairly and equitably, ensuring access to care regardless of disability or other factors. So how would I apply justice in this case? The dentist has an ethical obligation to provide the same standard of care to this patient as to others, not to refer them elsewhere simply due to discomfort or unfamiliarity. The practice as a whole should also assess whether the clinical environment is physically accessible in terms of wheelchair access, adaptive equipment, and inclusive policies. So here we should think about promoting equality in access to healthcare and treatment. Disability should not be a barrier to receiving competent care. So in considering this case, other practical recommendations for the dentist to think about can include engaging the patient in a collaborative dialogue about their needs and preferences, consult resources on adaptive dentistry, or consider referring to a specialist in special care dentistry if truly necessary, but not as a default. Request assistance from clinical staff or arrange for training on accommodating patients with physical disabilities. And lastly, document the patient's preferences and needs for future visits to build continuity of care.
So how would the Foundations of Professionalism document help dentists navigate this scenario?
Okay, great question. So the Foundations in Professionalism document modernizes and clarifies expectations of professionalism for dentists. When applied to caring for a patient with physical disabilities, the guidance can help dentists navigate challenges and deliver care that is inclusive, respectful, and ethically sound. So how do we do this? The guidance provided by the document places strong emphasis on tailoring care to the individual needs of the patient, emphasizing person-centered care. How do we apply this? For a patient with physical disabilities, this means adapting communication, treatment plans, and practice accessibility to ensure that the patient is fully involved in decisions about their care. The guidance document also highlights the importance of treating all patients fairly and without discrimination. This promotes equality, diversity, and inclusion. How do we apply it? Dentists are encouraged to proactively remove barriers, physical or attitudinal, that may hinder a patient with a disability from receiving care. The guidance document also encourages clear, compassionate, and adaptive communication based on individual needs, allowing for effective communication. So again, how do we apply the document? For patients with speech or mobility challenges, dentists might use written communication, visual aids, or involve caregivers or interpreters where appropriate. The guidance document also stresses collaboration with the patient in care planning, with emphasis on shared decision making. We apply this with patients with disabilities, as they should be fully involved in their decisions, with reasonable adjustments made to support their understanding and autonomy. So just to quickly summarize, the document equips dentists with a values-based framework to deliver equitable and inclusive and person-centered care, to reflect and adapt their practice to meet diverse patient needs, to engage in ethical decision-making, and lastly, to uphold trust and professional integrity, especially when working with vulnerable populations.
Thanks, Nancy. Now, you mentioned a little bit about communication, which is a central concept in all of what we do. What strategies would you use to communicate effectively and respectfully without making assumptions about the patient's abilities or preferences?
Okay. So effective communication should be patient-centered, respectful, and assumption-free. So a few points to consider in this scenario are the following. Use open-ended and neutral questions. So rather than presuming limitations, ask, what positioning worked best for you during previous appointments? Or are there any adaptations that have helped you in the past? Or how would you prefer I assist you? This respects autonomy and recognizes the patient as the expert in their lived experience. Speak directly to the patient. Even if a caregiver is present, maintaining eye contact and addressing the patient first, it reinforces dignity and it avoids paternalism. Ask before assisting. Never initiate physical help without consent. For example, a simple question such as, may I support your arm while we adjust the chair? This can avoid physical and emotional harm, and that promotes nonmaleficence. We can use clear and adaptive communication by obviously speaking clearly and calmly, allowing extra time for responses, or even offering written or visual explanations. They can also be helpful. And also confirm the understanding through shared decision making. Avoiding assumptive language or statements such as, you probably can't, or this might be too difficult for you. Instead, use neutralizing phrases like, would this be comfortable for you? Communication should preserve dignity, autonomy, and trust, aligning with the person-centered values emphasized in the document's framework.
What role can interprofessional collaboration play in supporting patients who have complex accessibility needs?
So let's discuss interprofessional collaboration and how it can enhance both patient safety and quality of care. So when thinking about improving safety and positioning, consideration can be given to consulting with occupational therapists or physiotherapists or special care dentists, as these various circle of care partners can provide us guidance on safe transfers, optimal positioning, muscle spasticity considerations, and assistive devices. This supports nonmaleficence and beneficence. When thinking about enhancing preventative care, considerations can be given to collaborating with caregivers, speech and language therapists, community nurses. These circle of care partners can improve oral hygiene routines. They can help assist with home fluoride usage, and they can also help with dietary counseling. When thinking about promoting holistic and coordinated care, patients with physical disabilities may have complex medical histories. So coordinating with their GPs or special care physicians can ensure that there's medical stability, there's medication awareness, and we can also help with comprehensive care planning. And so this, in essence, helps to reduce risk of harm. It promotes equitable access. It demonstrates professional humility, and we uphold justice by ensuring patients receive the appropriate support that they need.
Thanks, Nancy. Now, if there's anybody, if you feel you lack experience treating patients with physical disabilities or complex needs, when would you say it's appropriate to refer? And how would you ensure continuity of care?
Okay, so let's consider when it is appropriate to refer and how to ensure continuity of care. So some appropriate reasons for referral can include the following. The practitioner lacks the competence, skill, or judgment required. The physical environment cannot be made safe. The patient's medical complexity exceeds the scope of the general practitioner, or specialized equipment may be required. Referral, however, is not appropriate if it is based solely on discomfort, or it is due to unfamiliarity alone, or if it's motivated by inconvenience. There must be a balance between non-maleficence, avoiding harm, and justice by not denying care unfairly. Before I elaborate on this question, I'd like to point out an excellent resource tool, the Canadian Society of Disability and Oral Health, the Case Complexity Tool. It is a practical resource designed to help dentists and dental teams provide better, more consistent care for patients with special health care needs. So how do we ensure continuity of care? Be transparent. Explain the reason for the referral. Example, to ensure your safety and comfort, I believe a specialist setting with additional training and equipment may better suit your needs. Provide a formal referral letter with clear clinical notes, relevant medical history, and any specific concerns that you might have. Maintain communication with the specialist. Offer ongoing care within your competence, for example, providing preventative appointments. And lastly, document the discussion and shared decision-making process. Ethically, referrals should be framed as acting in the patient's best interests, not withdrawing care.
How would you balance your own physical health and safety and your ability to perform the necessary procedure when maybe positioning the patient is challenging, such as when they can't be reclined back?
Dentists have ethical duties not only to patients, but also to themselves and their staff. Protecting practitioner safety aligns with professional responsibility, workplace health standards, and sustainable practice. Some practical strategies for consideration can include the following. So you can think about modifying your clinical setup by adjusting your operator stool rather than forcing patient repositioning. You can work from an alternate clock position. Obviously, using magnification loops and ensuring proper lighting is appreciated and recommended, and raising the patient only to the extent where safety is only possible. Avoid unsafe postures. If a patient can't recline, don't excessively flex or rotate your spine. Use indirect vision where possible and break procedures into shorter sessions. Seek assistance by using trained staff for stabilization or retraction, and consider referral if safe ergonomic practices are not possible. And lastly, reflect on your own personal limitations. And what you can do is maintain safe posture is consistently impossible for you. Continuing treatment may compromise your musculoskeletal health, your treatment quality, and the long-term patient safety. So balancing care means upholding beneficence for the patient while upholding non-maleficence toward yourself.
Thank you, Nancy, for taking us through this scenario and for showing us how all four of the bioethical principles and how our document can help to navigate a situation such as this.
Thank you.
Let's move on to our third scenario, where we're going to call on Bonnie. So here's the scenario. Over the past year, a dentist has begun noticing troubling patterns in a colleague's behavior. Several patients have shared that they felt dismissed or disrespected during appointments with his colleague. They also reported feeling pressured to proceed with expensive treatments. When patients asked about simpler or more affordable alternatives, the colleague would respond that the proposed treatment was already the best option for them. The relevant bioethical principles to consider in this scenario are patient autonomy, beneficence, and non-maleficence. So Bonnie, can you speak to these relevant principles and explain how you would weigh them when deciding what to do? And how would the new Foundations of Professionalism document help dentists navigate this scenario?
Well, thank you, Erin. In this scenario, we have a dentist contemplating what to do when they have a colleague who is displaying troubling behavior. I will first discuss the relevant bioethical principles before discussing possible courses of action. So let's talk about the colleague. It appears that the colleague is not respecting patient autonomy as they're not engaging in shared decision-making. In fact, it looks like they're shutting down any conversations with the patients, and they're taking a paternalistic approach by dictating what the treatment for the patient should be. When patients doubt whether they are proceeding with the correct treatment, it may be a sign that the colleague is not fully explaining the treatment options and the risks and the benefits. And in that case, the colleague may not be reaching their legal and professional obligations for informed consent. Second, the colleague may not be demonstrating beneficence if they're not providing a safe environment for patients to discuss treatment options or bring up concerns. Instead, patients are feeling dismissed or disrespected. And third, the colleague may not be demonstrating non-maleficence if they're not complying with legal, professional, and ethical obligations set out in law and the RCDSO. And when we're talking about non-maleficence, it doesn't just refer to physical harm. It can also refer to emotional distress, loss of trust, or unnecessary financial burden on the patient if the colleague is just presenting the most expensive treatment options and ignoring less expensive treatment options that are still clinically acceptable. And so now we'll turn to the dentist who is contemplating what to do with the colleague who has troubling behavior. the dentist has the difficult task of deciding how to balance these competing bioethical principles. Regarding patient autonomy, the dentist must question if the colleague is actually obtaining full informed consent. Is the colleague providing the rationale for the treatment and all the benefits and risks of the treatment options? And oftentimes with dentists, when we encounter common clinical scenarios, we go through scripts. So we automatically go into the treatment options, the benefits, and the risks. But sometimes for patients, it might be overwhelming for them to receive such an amount of information. And it might be helpful for us to just pause and let this information sink in and give the opportunity and the space for patients to think about the treatment options and let them have some time to come back to it. Also, informed consent is a process, as we all know, and it's a two-way street. It's not helpful for the dentist just to give all the information to the patient, but not allow them the opportunity to ask questions or clarify things. So it's a two-way process. And if the colleague is actually persuading the patients to accept the most expensive treatment options, there are two concerns here. So the first is the dentist must consider, is the colleague presenting these treatment options first and foremost for the benefit of the patient's health and well-being, or are there conflicts of interests, such as financial pressures, which are mainly driving these treatment recommendations? And the second is the colleague expressing professional bias? And what I mean is the colleague may just present the most beneficial treatment options for the patient, thinking that they're helping the patient, but sometimes what the dentist thinks is best is not what is best for the patient. Dentists have the responsibility to incorporate patient preferences, values, beliefs, goals, and economic circumstances in their treatment planning for patients. And treatment planning that incorporates this is considered patient-centered care, which is elaborated in the Foundations of Professionalism document. So now we return to the overarching question. Should the dentists raise their concerns about their colleagues' behavior? The Foundations of Professionalism states that one of the duties of nonmaleficence is raising concerns about inappropriate, unprofessional, or concerning behavior of staff or colleagues directly with the person, or if needed, with the relevant leadership or authority. As the colleague is not demonstrating behavior that is consistent with the bioethical principles, and patient well-being and trust may be at risk, it would be prudent for the dentist to raise their concerns about their colleagues' behavior. I would advise the dentist to seek out more information to make sure that they have a clear grasp of the situation. And they should make sure that this is not just an isolated incident, but there's a clear pattern of behavior before approaching the colleague. And the dentist should also ask such questions as, what are the words or the tone that the colleague is using with patients? Is the colleague truly being dismissive? Or is the colleague coercing the patients to accept these expensive treatment options? And so I would just ask the dentist to make sure that they have truly seen the grasp the situation. And another factor I would consider is the dentist's relationship with the colleague. Do they have a good relationship? Does the dentist feel comfortable enough with approaching the colleague and bringing up their concerns? If the dentist is comfortable enough with bringing up the concerns with the colleague, I would advise the dentist to use neutral, open-ended questions and focus their discussion on things like shared goals, like patient care and trust. And that way, the colleague won't be feel as defensive and won't take this as a personal attack. So the dentist, for example, might say something like, I've noticed that some patients seem unsure about their treatment options after their appointments. How can we make sure that patients feel empowered to participate in their treatment decisions? And in this way, you're focusing more on the patient's right to participate in their treatment decisions rather than on the colleague's behavior. And the dentist could also say something like, I know you want the best outcomes for your patients. Some of them have mentioned feeling unsure about the treatment they're receiving. Maybe we can work together to make the rationale for the treatment clearer so they feel more confident in the treatment plan. And then again, you're focusing on solutions rather than judgments on the colleague's behavior. It's important for the dentist to show that they are providing support and not judgment. And if the dentist feels comfortable, they can perhaps offer their help in making patient materials or advising on communication strategies or providing them with like informed consent materials so the colleague has a chance to improve their practice. And if the dentist is actually not comfortable with approaching the colleague, it's okay for them to find another colleague or a trusted staff member to confide in. It's okay to seek out the opinions of others because they might see things from a different perspective or they might advise other things to do. And if the dentist is truly not comfortable with doing either of these, they can always contact Practice Advisory Service at the college. And so I'd just like to reiterate what others have said, that the Foundations of Professionalism document is not meant to give step-by-step instructions for every potential clinical scenario, but instead gives a framework or a systematic way of navigating ethical situations consistent with the values of the profession.
Hey, Bonnie. You mentioned in passing, I'd like to circle back to something that you touched on, and that's conflicts of interest. So how would you assess whether any conflicts of interest, such as financial or productivity pressures, are influencing treatment options that the colleague or even yourself are presenting to patients?
Okay, so if I wanted to assess whether any conflicts of interest were influencing treatment options, that the colleague is presenting to the patients, I would first ask myself 3 questions. The first one would be, are the colleague's recommendations financially based, or are they evidence-based? If they were evidence-based, I would hope to see that the colleague would present the full range of treatment options and not just the most expensive ones. And conversely, if the patient had financial limitations, for example, if they were on public dental insurance, I would also like to see the colleague present all the spectrum of treatment options and not just the least expensive ones that they think the patient can afford. This is part of justice, which is treating everyone fairly without bias and discrimination. And the second question I would ask is, are the colleagues' recommendations transparent? And what I mean by this is the colleague providing the full rationale? Are they providing all the treatment options as well as the risks and benefits associated with them? We have to give enough information for patients to make decisions, which is an important part of patient autonomy. And then I would also ask, what is the quality of communication between the colleague and their patients? When dentists engage in open and compassionate dialogue with their patients, it shows that they value patient autonomy and trust. If they're not presenting all the evidence-based treatment options, or if they're using pressure tactics, or they're dismissing patient concerns about costs, then this behavior may signal that their treatment options are being influenced by financial pressures. So for a dentist who is not being influenced by financial pressures, I would expect them to present a full range of evidence-based treatment options and discuss the rationale for the treatment, along with the associated risks and benefits of the treatment options. Thanks.
Now, That's a very patient-centered response. So along those lines, how would you support patients who feel dismissed and disrespected or pressured without undermining your colleague?
So my main priority would be to make sure that the patient feels heard and supported. I would listen very carefully to their story, acknowledge it, and I would thank them for sharing their concern. I would also want to clarify the clinical information. So I could say something neutral like, let's go over the options again so you feel fully informed. My aim is not to contradict or undermine my colleague, but just to get a full sense of what the patient's understanding is of the treatment planning. And I would also consider facilitating a discussion between the colleague and the patient again, if the patient was comfortable enough with this, just to clarify any misconceptions or any things that they weren't sure of. But if the patient wasn't comfortable with doing this, I would consider referring the patient to another practitioner to get a second opinion.
So if your colleague doesn't respond positively to your questions and your concerns, what would your next steps be?
So it also depends on how the colleague responds. If the colleague is flat out denying any wrongdoing or not responding, like being belligerent, I would not engage with them. But I would want to um, also perhaps say something neutral just to get my point across to something like, I know you want the best for your patients, but I just want to let you know. I the important thing I would do is to focus my conversation again on shared goals and not on making comments on the colleague's behavior because they obviously feel threatened or defensive about this. So I would also consider reaching out to trusted colleagues and trusted staff members just to get their perspective. And if I couldn't do that or I wasn't felt I still need to reach out to someone, I would probably reach out to the practice advisory service at the college. However, if the colleague did have a more calm response or they showed a more willingness to listen, then I would probably gently have a discussion with the colleague about how their patients are feeling dismissed and perhaps not heard, because perhaps the colleague is not aware that their tone is maybe dismissive, or sometimes they might not know that their tone sounds terse or blunt. And in that case, this could be sort of a teachable moment for the colleague. And of course, I would offer help and support rather than judge the colleague, and would focus on shared goals of patient well-being and trust.
And one final question for you, Bonnie. How would you manage the discomfort or the stress that can arise when you're thinking about and when you're addressing concerns about a colleague?
So before addressing the colleague, I would first want to make sure that I had all of the information to make sure I had a clear view of the situation. But I would also just ground myself in knowing the goal, the goals that I'm trying to achieve, and that is patient safety and maintaining professional standards and yes, patient well-being as well. So um, I would also consider as well talking with trusted colleagues and other staff members to get their perspectives and just to see if I'm approaching the situation professionally and constructively. And of course, if need be, I would contact the practice advisory service at the college.
Thank you, Bonnie, for taking us through our third and final scenario. So in closing, I have one more question for each panelist, and I'll kick this one off with a little bit of storytelling. So I'd like each of us, or a few of us, to tell everybody about a time when you or someone you know has struggled to make a decision. And everybody listening, you can think of your own experience as well. and reflect on that either during or after our own stories, and how would the Foundations of Professionalism document have helped. So an experience that comes to my mind just before, literally a week before we had our COVID lockdowns in 2020, I did my first and only so far, but hopefully not last, rotation up to a remote area in the ODA's remote areas program. And this was 2 weeks working in a clinic on a native reserve with a small Indigenous community. So one of my first patients was an elderly woman, and she shared with me her experiences surviving a residential school. And she shared with me how these experiences had impacted her relationships with people of authority, like teachers and healthcare professionals, how these experiences had impacted, well, herself and also her family, and intergenerational trauma. And this was striking because when I started this rotation, I didn't know what I didn't know. So listening to this story really put a lot of things into context that you don't necessarily see every day, depending on the nature of your practice, but they're very, very prominent issues. So where I put these into use is a few days later, I had a young patient come into the clinic for a checkup. And she came in with her mom and her dad and sat in the chair and was really anxious. So wasn't really inclined to cooperate or let me look. Was withdrawing into like her mom and her dad. I'm sure everybody has seen patients like that who you just can't get any interaction out of. So this patient was 8 or 9 years old, so school age. And in the city and in dental school, you learn a certain way of dealing with children. So you have certain tools. You've got the tell, show, do. You've got things like voice control that you can try. So with this patient, as I would normally do in my own practice with a school-age child, I asked the patient's parents to leave the room because I thought that if they weren't there, then I could focus on developing a relationship with the patient and maybe get somewhere without having them for the patient to deflect to. So as soon as they stepped out of the room and I closed the door, my patient bolted. And I have never seen somebody look so incredibly terrified. So immediately I remembered what my older patient had told me about her experiences growing up and about how this had affected her and her family and the community as well. So in this scenario, to refer this back to the document, this suddenly shifted how I looked at these bioethical principles. So suddenly the most important principles at hand were autonomy and nonmaleficence, because I realized here that if I had misstepped or shown any kind of force or done anything to try and overpower this patient or increase her fear, that was going to be causing a lot of harm. And potentially this could be permanent harm that would preclude her from ever seeing a dentist again or trusting anybody in authority. So what I did is I stepped back and I said to her right away, I said, it's okay. I'm not going to do anything that you don't want me to do. I'm not going to do anything that you don't think is okay. I said, I'd really like to look at your teeth, but I'm only going to do that if that's okay with you. So then we pulled out all kinds of creative things. So we did a mock appointment with a dental assistant, and then I think we ended up just playing and having fun in the office. And by the end of the appointment, she would only let me look at her teeth from across the room, but she was happy and she was smiling and laughing. And when I brought the parents back into the room, I feel like we developed a little bit of a relationship based on trust. So I think this scenario really highlights how these different principles can be of different importances in different contexts. And you have to be sensitive to that, and you have to really understand the nuances, and you have to understand what's going on and what you're dealing with. So that you can make decisions that are right for the situation at hand. Let me pass the baton on to Kevin. Maybe you can share one of your experiences.
I can try quickly. I know we're almost on time. So I remember experience many years ago. It kind of relates to the scenario that I had where a patient presented for emergency. This was relayed to me by some other dentists, but the patient presented to emergency call, and the young dentist did the exam, came up with the treatment plan. The patient was in extreme pain with the lower incisor and was insisting on having the tooth out, similar to our other scenario. And the young dentist thought they went through the informed consent and looking to provide the patient's autonomy or respect the patient's autonomy and remove the tooth, and said he could do the other treatments such as root canal treatment. Patient declined, wanted to have the tooth out, so he took the tooth out. When the senior dentist arrived to see the patient with the missing tooth, the comment from the patient was, "Oh, I didn't know the space was going to be that big, or I wouldn't have let him take the tooth out." So I think that weaves in with the foundations document, autonomy and non-maleficence, and it kind of relates to the scenario that I had as well. And maybe that's why I'm traumatized and I don't want to take a tooth out because I was involved in that experience. But I think it's important that we do put ourselves in the patient's position and make sure that we've provided all the options or all the consequences rather as well, and so that we've got our patients properly informed as far as consent to treatment. So this document, I think, again, providing the checklist will help dentists, young and old, to navigate these scenarios.
Thank you, Kevin, and thank you to all of our panelists. I think I'm going to pass things back now to Andrea for some closing remarks.
Great. Thank you so much, Erin and Bonnie and Kevin and Nancy. What a great discussion. Really appreciate you taking the time to be with us tonight. And to all of our attendees, thank you so much. It's wonderful to see this session so well attended. And it's such a rich topic. So I really hope you've taken something away tonight to think about and some resources to access. For your CE points tonight, you don't have to do anything. We will take the information from Zoom and use that to generate your CE certificate. So we'll get those out to you within 5 business days. As always, if you have practice-related questions, please do reach out to the college's practice advisory service. I know some of our speakers mentioned it. We have a wonderful team who are really skilled at answering questions. We have practicing dentists who are on that team. So please reach out to them with some specific questions. We also have a wealth of resources on our website. So the documents that you've been going through tonight are on our website, along with some really practical resources. To keep informed of what we're up to at the college, please do follow us on social media. You can get our latest news and updates and resources. And we hope to see you at a future RCDSO Connect session. Our next virtual session will be taking place on April 22nd. So please watch your emails for details about that event. Thank you again so much and enjoy the rest of your evening.